sleeping, but insomnia per se, this difficulty not sleeping 3 nights a week, 5 times a week, is a disorder, and it's very specifically a chronic disorder. It's not going to go away unless you treat it. I'd love to tell you it gets worse if you don't treat it, but I have no data to support that. It is associated with significant morbidity, and while we focused for years and years on morbidity such as risk of depression, pain, we now know that things like hypertension, obesity are also risk factors. And 2, and finally, it's a disorder of hyperarousal. My time is 6 seconds away, so thank you very much. And I think we have some time for questions.
We have plenty of time for questions, so send the mic. Can we get the mic on?
Is it on? Oh,
yeah.
Can you comment on the recent findings of increased risk of death with chronic hypnotic use?
Sure, that's a shocker. I just was not expecting that. Okay. First, the question is, if in the BMJ about a month ago, in every newspaper in the country, there was an article that suggests that if you use hypnotics in general and zolpidem specifically, you have an increased risk of mortality. Okay, and an increased risk of cancer. You know, first of all, Dr. Kripke has published this about 4 times. This was first published in 1969 in the Archives of General Psychiatry on a database called ANN. So this is not new data. Now, what's very, very important to understand is whenever you do relative risk studies, and what we're talking about, so for example, if I do a relative risk study of people taking hypnotics and people not taking hypnotics as a risk for falls, what's the result of that? People taking hypnotics have more falls. What do we know now, based on Dr. Avedon's statement, that insomnia? So the basic assumption of his hypothesis is that people with insomnia, people who take hypnotics, are exactly the same as people who don't take hypnotics. And hence, that's his comparison group, have higher mortality. So 1, he doesn't control for insomnia, and I'll get back to that in a minute. B, how many people in here, well, everybody here practices psychiatry. How many people know that whether psychiatric diagnosis go on the medical record? They don't. Hence, he didn't control for psychiatric diagnosis. He certainly didn't control for medications, any medication. He didn't control for any medication. Some antidepressants carry a risk of suicidality in certain populations. So he didn't, he didn't control specifically for psychiatric diagnosis. He didn't control. One of the things that's fascinating in this study is he also points out that if you look at a dose-response curve, i.e., people take sleeping pills once a month, people take sleeping pills 6 times a month, people take sleeping pills 12 times a year, whatever it is, have higher mortality risks. If you take sleeping pills once a year, 30 times a year, or 100 times a year, what's that dimension? He calls that a dose-response curve. What do you call that? I call that severity of insomnia. The dose is the same, right? If you have insomnia 365 nights a year, that's more severe than if you had it once in the last year. And very clearly, that was a significant risk factor. So there's lots of things wrong with that paper. And actually, probably one of the best critiques of that paper was if you read the New York Times last Sunday's op-ed section, Week in Review had a comment. But go online. There's a lot of discussions. Look at the reviews of the paper. And again, most importantly, this is not new data. It's been around a long, long time. It's just the same data of a new database.
Yes, the right one.
This question has to do with the slide that you showed up of the PET scan and hypermetabolism,
right,
and also the rectal temperatures and increased temperature.
Right.
And in the epilepsy literature, there is evidence that brain cooling will decrease the rate and firing of epileptogenic brains by actually cooling the brain. And I'm wondering if there are any animal models or any human models of decreasing the brain temperature to go about treatment of insomnia.
This is 2012. This isn't a time of research. This is a time for company. There's a company doing that. There are clinical, there's actually been an abstract published at the sleep meeting of a device that's sort of like a bicycle helmet, cools the brain, improves insomnia? Great question. It's been, you know, and it's a great question because somebody's done it, obviously. Now, there's a preliminary data. There's a NIH-funded, very, very large SBR grant looking at that right now. A great question. But those things are very different, by the way, because one is brain temperature, and the core body temperature are very different things. I don't think that reducing core body temperature is going to do anything. But I don't know that. But I think he's reducing, and by the way, the guy who's doing this work is Eric Knopfson, the guy who showed increased brain metabolism. Great question, thank you.
Do patients with chronic insomnia who take benzodiazepines, do they develop tolerance over time and require higher doses?
I will talk about that in my next lecture, but the answer is no.
And is there any risk of dementia, just like alcohol can cause dementia, can chronic benzos?
I know of no studies which have shown that, but again, I'll talk about medications at I think 11:30.
Thank you, a great presentation. I never thought of insomnia as a risk factor for depression. I always thought of insomnia as a risk factor for bipolar, but I don't know the literature. So can you comment on the relationship?
Sure. Well, you know, first of all, it is very, very important to understand, you know, one of the things I sort of said is there's a difference between sleep deprivation and insomnia. I think that's a really important thing. You know, bipolar patients, by and large, don't have insomnia. They just don't even go to bed. Right? I mean, you know, we try to do a sleep study in people with bipolar, get them in a lab for 8 hours. Sure, that's going to happen. And there's very little question. There's very little question that sleep deprivation, you know, will in fact, I mean, stimulating people will in fact drive manic episodes. In fact, you know, there's just terrific data. Dr. Goodwin's, I think, presented already. You know, one of the things you can track people is their sleep habits. As soon as they stop spending 8 hours in bed, they're about to have a manic episode.
But it's true that they don't go to bed, but some of them who start getting better and most of the symptoms go away, they still can say, some of them will say, I have racing thoughts,
absolutely,
my mind is going fast and I can't sleep. And
no question about that. You know, having bipolar does not immunize you from having insomnia. I totally agree with that. And in fact, the prevalence is higher in that population, just as it is in depression. But I think you're right. I mean, but why don't we think about this in depression? I think we didn't think about it in depression is because we sort of always worked on the assumption that the depression predates insomnia. I was one of the people who authored an article in 1985 saying if you have insomnia, depression, treated depression, insomnia went away. And the reason we thought that, by the way, why do we think that? You know, apropos to the last lecture, if you had depression in 1985, what do you get to treat your depression? Amitriptyline. That'll fix your sleep 100 times out of 100. We don't give them amitriptyline anymore. So that's what we thought that.
thank you.
Thank you.
Over there, lady.
Could you comment on changes in sleep and menopause?
Sure. It's a relatively complex issue. There's a very, very high. There are lots of changes. One of the things that's very, very important is there's a dramatic big increase in the prevalence of sleep-related breathing disorders. One of the things that's really interesting in the United States is if you're a 55-year-old overweight man with a big neck who snores, the probability of being diagnosed with sleep apnea is very high. If you're a 65 or 55-year-old thin woman, the prevalence of sleep apnea is actually higher than in that man, but you're not going to get diagnosed. Above the age of 65, obesity is not a risk factor for sleep apnea. So lots of things happen. With menopause, women have very high rates of insomnia. We don't fully understand the relationship of that and hot flashes. Dr. Friedman at Wayne State University does a lot of research on that. So we don't fully understand the relationship of hot flashes and insomnia. But there's certainly an increase in the prevalence of sleep disturbances, an increase in the prevalence of sleep apnea. It also was very important about that is it provided me with a very important answer to a question I always get whenever I lecture on sleep. I always get asked, what is the ideal temperature for a bedroom? And I have learned it is whatever your wife tells you it should be. I find out when she likes the temperature, I sleep better. Who would have known that? They never told me that in school.